Okay, good morning everyone. Today we are going to continue with our book club activity. Two chapters today about the benign cystic bone lesions and about the malignant bone lesions will be presented by our colleague Dr. Adina. May she start.
Good morning. So today first I will start with the benign cystic bone lesions. There's synonyms for differential diagnosis of benign cyst lesions mentioned in the book. However, our teacher suggested a better name we can easily memorize. It's called fog machines, representing the F for fibrodysplasia, O for osteoblastoma, G for giant cell tumors, multiple myeloma and metastasis, and so on. Each letter is for a specific disease. So we'll start with the fibrodysplasia. This is a benign congenital process that can be seen in a patient of any age and can look like almost any pathological process. Wild looking, discrete lucency, patchy, sclerotic, expansile, and multiple. They can have off-ground glass background or matrix, or even can be purely lytic. However, the discriminator for this lesion doesn't have any periosteal reaction, which almost seen in any lesion. Fibrodysplasia virtually never undergo malignant degeneration and should not be painful unless there is a fracture. Fibrodysplasia can be monostotic, which is the most common type, but also it can be polystotic, means more than one bone. And this has predilections for the pelvis, proximal femur, ribs, especially the posterior portion of the ribs and the skull. So these are examples. This is case also of fibrodysplasia, including both the femur and the pelvis as well. This is another example as well, including the metaphysis in the neck of the femur as well as the acetabular surface of the ilium. This is another lesion including the femoral neck, and as you can see, this is with a sclerotic margin. This is also fibrodysplasia seen in the posterior ends of the rib.
So, regarding fibrodysplasia, first there are some few interesting points here. If it involves the pelvis, the femur is involved. If it involves the femur, the pelvis may or may not be involved. Every pelvis must have a femur, but not every femur there will be a pelvis.
Sometimes
First.
in this case pairs.
Second, it can look like anything. Can be lytic, can be sclerotic, can be mixed. You can see here it has a narrow zone of transition, a sclerotic border, perfectly benign, while on the other hand it can have a lytic appearance. So you should keep it in mind. Okay? Any age, any appearance. Any place you can put fibrodysplasia, it will be correct.
Fibrodysplasia, also the polycystic, can be seen in this case in the radius of the child, and as you can see, it's hazy, ground glass appearance. Some of the lesions are lytics. The main differential diagnosis for this case, which can be similar adenomatoma, which is a malignant lesions usually encountered in the tibia and the jaw, although it's rare, and can sometimes resemble to the fibrous dysplasia, such as in this case.
It's حصرا tibia and jaw.
Yes. Mm-hmm.
If it's not in the tibia, it's not adenomatoma.
Yes. The other lesion is enchondroma. This is occur at any bone formed from cartilage and maybe central, eccentric, expansile, nonexpansile. And invariably they contain calcified chondroid matrix, except in the phalanges, such as in this case. Usually it is loosened without calcifications. So the discriminators for this will be have calcification, as we said, except phalanges, and there is no periosteal reactions. And characteristic with these snowflakes calcifications.
These are typical chondroid calcification.
Yes.
Popcorn-like, flake-like, snow-like, whatever you like to describe, but it looks like that. This is chondroid pattern calcification.
Okay. One of the main differential diagnoses which most radiologists sometimes get confused is the bone fraction, because sometimes they present as lytic lesions at the metaphysis reaching to the epiphysis, and sometimes they have calcified serpentinous borders. So sometimes these faint calcifications, such as you can see here, sometimes can be misleading. Two main diseases we all know is Euler and Maffucci syndrome. Both of them are, they said, hereditary. However, Euler usually just multiple enchondroma, and they do not have any malignant degeneration. However, Maffucci you present with multiple hemangiomas, enchondroma with multiple hemangiomas, and they have incidence of turning to malignant degeneration.
Multiple enchondromatosis is Euler disease.
Yes.
Multiple enchondromatosis plus soft tissue hemangioma is Maffucci syndrome.
Yes.
How do we know there is soft tissue hemangioma? By looking for phleboliths.
As
You
well.
can see the calcifications, the phleboliths here in the soft tissues, confirming there are hemangiomas. Okay?
Third lesion is eosinophilic granuloma. This is a form of histiocytosis X, and it has many appearances as well: lytic, sclerotic, well-defined, sclerotic border, may or may not enlist a periosteal reaction. The periostitis present typically, usually in benign in appearance if it presents, thick, uniform, wavy. However, also it can be lamellated, amorphous, aggressive. But the discriminator of this lesion is young, less than 30. Eosinophilic granuloma occasionally can have a bony sequestrum, and we put it under the differential diagnosis.
When you see a bony sequestrum, you have one of three: either osteomyelitis, fibrosarcoma, lymphoma, or eosinophilic granuloma. Three differentials plus eosinophilic granuloma.
Yes.
First. Second, in case someone don't know, periostitis means periosteal reaction. Okay, when we say periostitis, we are talking about periosteal reaction. There are benign forms of periosteal reaction and malignant forms of periosteal reaction. Benign forms is when the process happens slowly. Okay? بالبون ما عندنا malignant و benign. عندنا aggressive و non-aggressive. Okay? Aggressive اللي هو ايش؟ من malignant, infection, and شو بعد؟
infection exception بالbenign.
هاي aggressive lesions. Okay? Can be benign. Okay. Infection is a benign process but aggressive.
Yes.
Okay? لأنها rapid. The slow process اللي هي other pathologies, benign pathologies. فيعطيك slow process will result in slow periosteal reaction. اللي هو lamellated, thick, solid, wavy, uniform. In rapid process, an aggressive process will result in immature periosteal reaction. Yeah, it takes time for the periosteum to become mature. هذا aggressive process بسرعة يصير. ما يعطي مجال. It will not give time for the periosteum to react in a good way. Okay? So there will be aggressive form of periosteal reaction. اللي هو شنو؟ الكولبرن triangle, lamellated appearance, sunburst pattern. كل هذه aggressive forms of periosteal reaction. So if you see benign form اللي هو thick, wavy, solid, uniform, هذا benign or non-aggressive form of periosteal reaction. If you see aggressive sunburst to speculated to lamellated, this is indicate aggressive pathology, aggressive periostitis. Okay?
Also, this is examples of eosinophilic granuloma, including the acetabular surface of the ileum, and also this is also this is another case of lucent lesion and lytic lesion containing a bony sequestrum in the metaphysis of the humerus. Which was approved as eosinophilic granuloma. The next one is giant cell tumor. This is uncommon tumor found almost exclusively in the adult after the epiphysis is closed, in the end of the long bones, but also it can occur in the flat bones. 50% they say that it can have giant tumors will be malignant. However, the physician depend on its recurrence rather than the metastasis. So the discriminator for this lesion, it is epiphysis must be closed, must be at the articular surface, including the apophysis, which is seen in the greater trochanter of this lesion. It should be well defined with a sharp neurozone of transition. Mean sharp, we can draw it with a fine pencil, and must be eccentric in locations.
Should cut giant cell tumor لازم must about the articular surface. It must reach the articular surface of the bone.
Yes.
First. Second, لازم must epiphyseal plate closed. إذا opened, move. It's not a giant cell tumor.
Yes.
Okay? With a narrow zone of transition, sometimes you can have secondary aneurysmal bone cyst in the giant cell tumor. So you should keep it in mind.
Yes.
Okay?
We always put it in the differential. Now the only places that this criteria will not be applied, all of them, in the flat bones, in the pelvis and the calcaneum, such as in this case, in the wing of the ileum. This is also seen as a lucent lesions. So sometimes we do not need to apply all the four criteria. Surgeon usually just cortage the lesion and pack it, and they consider giant cell tumor of malignant degeneration unless when there is reoccur again.
Benign unless
يعني
recur.
reoccur again. Yes. Non-ossifying fibroma, this is the most common benign lesion we encountered, and most commonly, but they can occur up to 20% in the children, and usually spontaneous regress, so they will be seen rarely after the age of 30. And if they seen, they will be more sclerotic. One of the main synonyms is that fibrous cortical defects. Although the two lesions have, you will divide according to the size. If it's less than 2, this is fibrous cortical defect, such as in this example. And if it is more than 2, then it will be a non-ossifying fibroma. So the discriminator for this lesion is that it should be young, less than 30, no periosteal reaction, there is no pain, and they call it do not touch lesions. يعني.
Leave it alone.
Yeah.
Always
Leave
Leave
it.
it.
Don't worry. It will heal by itself.
I was 16. I got nervous. They removed the one.
Oh
Then
my
cured
God.
it
But
and taken
Well-
small graft from the iliac crest.
absolutely no need.
And I stayed on bed 15 days. 50 days.
Oh my God.
Usually it heals by itself. Just leave it alone. It has no malignant potential. حتى not that increase the potential of
Yes.
pathologic fractures.
I was feeling pain just on lifting heavily.
Sometimes, if a CT or MRI is obtained, they will be often appear to be an interruption of the cortex, and this can be misinterpreted as a cortical destructions. For example, in this case, after doing the CT, there is a sort of cortical destruction, and they said this is only just a cortical replacement by a benign fibrous tissue, so no need for any further
So if you see
investigation
the cortex
or management.
interrupted, it's okay. It doesn't mean there is a pathologic, a malignant process. Don't worry. No aggressive process.
In this case of healing non-ossifying fibroma, which appear expansile well-defined and of the proximal humerus in a child. It is asymptomatic, and will be, as you can see here, it is sclerotic because of the osteoblastic activity. And the interesting thing is that during the healing process it will be hot on bone scan. And however, occasionally it's rather than healing, it can get larger in size, such as in this case, it extends into the diaphysis.
You can see it looks large, looks terrifying, but narrow zone of transition, no cortical destruction, no periosteal reaction. The age is young, so it's just a non-ossifying fibroma. Leave it alone, follow it up by X-ray. After a few years, it will heal by itself. Don't do it. Unless there is a
Pathological, it will be.
it can be large. If it heals, there will be no pathological fractures. Okay? No, interruption. Don't think that is a cortical disruption. It just interrupted cortex, not destructive. It's not an aggressive process. It's a benign that interrupts the cortex.
The behavior is malignant in behavior, but it is benign.
No, not malignant.
It's a benign behavior
No periosteal
with
reaction.
cortical. If you see cortical interruption, don't worry. It's acceptable in non-ossifying fibroma.
Osteoblastoma, it is a rare lesions and have two appearances. One of them is look like a giant osteoma, and the other one is expansile, often of bubble appearance, look just like aneurysmal bone cyst. Commonly occur in the posterior element of the vertebral bodies, and about half of the cases demonstrate as speckled calcifications. So the discriminator, whenever we suspect aneurysmal bone cyst, we should mention osteoblastoma, especially if it was in the posterior element of the spine, just like in this case. There is expansilotic lesion, and on CT, obviously, it's seen that. And so we include two differential diagnoses in addition to the tuberculosis.
So TB, osteoblastoma, and
Aneurysmal bone cyst.
aneurysmal bone cyst.
Yes.
You should keep these three in mind.
Yes. Metastatic and myeloma. The main thing is that should be considered metastasis for analytic lesions, benign, aggressive in appearance in any patient more than 40, unless trauma arthritis is the primary concern. So the discriminator for these two lesions is that more than 40. In general, analytic expansile metastasis disease tend to come from the thyroid and the renal. The only metastasis that purely always lytic is the renal cell carcinoma. This is an example.
I think myeloma and metastasis should be considered in any bone lesion in patients more than 40,
Yes.
or in patients less than 40 with non-primary.
Yes.
okay?
Yes.
يعني يجي مثلا 10-year-old
Yes.
with neuroblastoma, for example, history, I think of bone metastasis. Why
Of
not?
course, yes.
Okay, but more than 40, think of metastasis and myeloma,
Myeloma.
even if no non-primary.
Primary will be.
If a female, think of breast. If a male, think of lytic. Usually think of sclerotic, sclerotic.
Yes.
Lytic might have renal, might have thyroid, might be colon, whatever.
Yes.
Okay.
Multiple myeloma also can be a diffuse permeative process in the skeleton, يعني solitary, sometimes multiple lytic lesions, and such as this is one of the favorite sites in the calvarium of the
Punched
skull.
out appearance.
Yes, mouth-eating appearance. Now, bubbly-lytic lesions of myeloma are more correctly called plasmacytoma and usually occurring in the pelvis at this site, where, as you can see here, this is lytic lesions. It is also one of the favorite sites. They said that plasmacytoma is slightly occur at younger age group. It means يعني 35 and above. And however, within 3 to 5 years clinically and hematologically, it will be multiple myeloma.
It's just like the cancer
Yeah.
tumor.
it's
Yes.
the same. At the end, all of them look the same.
Also, one of the most common site is in the vertebral bodies, and on cut sections or on axial section, it will look like it's called mini brain because resemble to the cerebral gyri
Looks
and
like a
sulci.
brain.
Yes, it's called mini brain, and this is characteristic for plasmacytoma. Aneurysmal bone cyst. This is the discriminator is that should be expansile and must be younger than the age of 30, and usually present with pain when it is expansile, although it will be asymptomatic and you will not know about it. They can occur anywhere, and as we said before, when osteoblastoma is mentioned in the posterior element, aneurysmal bone cyst will be with it.
Aneurysmal bone cyst can be primary, can be secondary. Secondary can arise in almost any pathology. يعني giant cell tumor يطلع بها ABC. Osteoblastoma يطلع بها ABC. Any pathology يطلع, and with it حتى trauma can happen. Okay.
Okay.
Hi first. It looks a lot like giant cell tumor.
Yes.
However, first the difference is the age. It's younger age group. The metaphysis, the
Epiphysis.
growth plate usually open, still open, not totally closed, and it does not reach the articular surface.
Surface.
So if it reaches the articular surface, it's giant cell. If it is not, it is an aneurysmal bone cyst. Okay? It's not reaching. حتى لو شوية. Not reaching.
If a fine of bone normal will be excluded. Also, this is two cases in the diaphysis of the ulna, and this is another seen at the posterior element of the vertebra. It has the typical fluid level and CT, on MRI, and however they said non-specific finding because not always it will be found. Solitary bone cyst, also it can be it's called simple bone cyst or unicameral bone cyst. They said 2/3 or 3/4 found in the proximal humerus and proximal femur. This discriminator should be central location less than 30, and there is no any periosteo reaction. Also, this is one of the fairly common location in the calcaneum and reaching the inferior surface of it. And also, this is a case of a solitary bone cyst, but with a pathological fracture. And presented, the classical finding is the falling fragment sign, and this indicates that the lesion inside is like a fluid or soft tissue component, so that the fragment will fall down. Hyperparathyroidism and round tumors. Also, they can have almost any appearance. The discriminator is that when we see lytic lesions with another evidence of hyperparathyroidism, we should think of brown tumor. Including this criteria, subperiosteal bone resorption in the medial aspect of the middle phalanges, distal clavicle, proximal tibia, and sacroiliac joint. And
Radial aspect.
medial aspect
Radial aspect.
of the phalanges, Doctor.
Radial aspect of the phalanges.
But he said medial of the tibia.
Oh,
he said.
sorry.
Yes.
I'm sorry, my mistake.
I will have a picture next slide. And they said also in the children, when the epiphyses are still open, they can also give a ragged appearance like a ricket. Okay, so this is an expansilotic lesion seen in the fifth. We see this fifth metacarpal bone, and there is another lucent lesion seen here at the proximal phalanx. However, taken on a close look, we found that patient have erosion at the radial aspect of the phalanx.
Parosteal erosion at the radial aspect of the middle.
With other
Typical
features.
for hyperparathyroidism.
Infection, this is have a variable appearance and can occur at any location and only be in any patient of any age, including the before 30 and after the 30. So the discriminator is none. So almost including any differential diagnosis. However, they said if bony sequestrum present, this is a strongly suggest this lesion, and for the surgeon different lesion because they will just remove it. So yes, this lytic lesions as we see it here on plain X-ray, and on CT we found the sequestrum. This is strongly suggestion. When osteomyelitis occur near a joint, and especially if the articular surface is abutted, invariably the joint will be involved and will show cartilage loss and effusion, or even both. For example, in this case, we found this lytic lesions, and on doing MRI, it found there is a slow, on MRI, there is a high signal associated with the joint effusion, and probably they said this site is a connection with the joint and causing, representing a drainage abscess of the same case.
Osteomyelitis changed into septic arthritis.
Yes.
Pus in the joint, this will be an emergency, it needs immediate evacuation.
Chondroblastoma, it is one of the rare lesions, and the discriminator is that less than 30 and must be epiphyseal, must be. Other epiphyseal lesions including the differential diagnosis is that infection, giant cell tumor, chondroblastoma, we said it, and Jude. And exception for this GOD, which is mean subchondrial cyst, is that in the flat bones we should not include this one. If no one knows Jude, it's usually occur in degenerative disease, in rheumatoid arthritis, in pseudogout sometimes, even avascular necrosis.
So GOD is just a subarticular cyst,
yes.
as part of an osteoarthritic changes and
yes.
other arthritis.
Yes. So this is a chondroblastoma, well-defined lytic lesions found in the greater tuberosity of the humerus. To comparison, this is a Jude large lytic lesion also in the proximal humerus, and in patient have a degenerative disease at the glenohumeral joint. Chondromyxoid fibroma also, it is a rare lesion. It basically resembles the nonossifying fibroma. However, the difference between them is that this can occur at any age, while we said non-ossifying usually younger. Often they extend into the epiphysis and usually present with pain, and sometimes it can have calcifications. For the comparison, this is non-ossifying fibroma.
I think never calcify this one.
Which one?
Not show calcification on any model.
No, sorry, yes. Absolutely right. So the differential, as you can see, this is reaching the articular surface and this one not. So this is non-ossifying fibroma and this is chondromyxoid fibroma. One of the differential just mentioned at the end of the chapter is the rib lesions, fibrous dysplasia, aneurysmal bone cysts, metastasis myeloma, and Enchondroma Eosinophilic granuloma. And also multiple lesions, specifically multiple, also they give this synonyms, but we suggest another name which is called Fahmy and represent F for fibrous dysplasia, eosinophilic granuloma as well, Enchondroma, hyperthyroidism, and the M and the infections.
Metastatic myeloma and infection.
Yes. Important thing is, as we mentioned, sometimes the lesion that's younger than 30, we mention it all. Eosinophilic aneurysmal bone cyst, non-ossifying chondroblastoma, and solitary bone. So if any of these lesions tend to be regress usually, and they often follow the new bone, as we said, sclerotic or blastic appearance. Now we will jump to the next chapter of malignant bone lesions. The author divides the radiological criteria of the malignant, or we said the aggressive tumors, into periostitis or the preosteal reaction. And we all know, as we mentioned before, there's a benign and aggressive. There is the cortical destruction, although sometimes we said benign lesion can have sort of cortical disruption or interruption. Orientation of the lesion or the axis, but this is very poor determined. For example, lymphoma will be grow with the axis, so this is totally not dependable. The most reliable sign is the zone of transition. We said noroid can be drawn with a fine point pain, while the wide we cannot clearly draw it. This is two examples of zone of transition. This is of non-ossifying fibroma, and this is a case of wide zone of transition in malignant fibrocystocytoma. You can barely see what is the edge of the lesion. Age of the lesion can be very helpful. If it is less than 30, we should always think of Ewing and osteogenic sarcoma. If it is between 30 to 40, we think of giant cell tumor, the malignant type. Parosteal sarcoma, which is one of the subtype of the osteogenic sarcoma, malignant, fibrocystocytoma, primary lymphoma. And if it is more than 40, as we said, we should think of metastatic and myeloma and add to it chondrosarcoma. Interesting that MRI, they said it's important in diagnostic of choice for the extent of the lesion in the skeleton and for soft tissue. They said almost all bone tumors will have a low signal on T1 and high on T2. However, exception of this is that MFH and desmoid tumor, they both of them because of more fibrous content, so will be low on both T1 and T2. Also, if the tumor contain calcification, it will be low as well in both sequences, T1 and T2 weighted image. Also, one of the advantage of the MRI, sometimes it can enable us a specific diagnosis made for the intraosseous or if it is a soft tissue tumor. Lipoma, for example, easily can be recognized by MRI with homogeneous high signal intensity on T1 weighted image, such as in this case, lateral to the femur, and you can see just have a signal intensity just similar to the fat planes with fine striations, and also hemangioma or any other malformations can have mixed of high and low signal on both sequences because the combination of fat and blood, so characteristically they have a low signal subpenthious vessels. So this case of hemangioma on T1 and T2 fat sat, they show a low signal mass with striplet areas of high signal representing between them, representing this is a vessels. On F2 fat sat, was inhomogeneously high signal with punctate areas of very bright signal. They represent this is the vessels, and this is picture of hemangioma. So as we can see, how does it important for lesions. Now, gadolinium administrations, they said should not be employed in imaging, especially if you suspect a bony tumor, because nearly all bony tumors will enhance, except if there is a necrotic area or foci of calcifications. However, gadolinium administration is used to differentiation between solid tumor and fluid, because solid tumor will be with contrast and fluid will have a rim enhancement. This is an example of lesion that is well defined, seen at the anterior thigh. On T2 fat side, it was very bright signal. We can say this is almost fluid. However, after giving administration, contrast, it has a heterogeneous enhancement, and it was proving that it is a schwannoma. Starting with the osteosarcoma, as we mentioned, this is one of the commonest malignant primary bone tumor, exclusively in younger age group, children and young adult less than 30. However, they said that there is another peak of the lesions at the 6th decade, but they say mostly when patients have Paget disease. Usually occur toward the end of the long bones, but it can occur anywhere, and usually it is destructive for the reactive sclerosis.
So when you see osteosarcoma in an elderly age group, it's Paget.
Paget.
Don't think twice.
Yes.
احتمال maybe radiotherapy, but usually it's Paget, especially in European countries. It's very common there.
Yes. So this is destructive. Mainly it is sclerotic, osteoblastic lesions, and there is a preosteal reaction. Osteosarcoma have many subtypes or classification, but this is the main four conventional in the central. Cylindritic usually contains small vessels, so it will be entirely lytic lesion. And there is the parosteal and periosteal. The difference is that parosteal growing from the periosteum outwards, while the periosteal from the endoosteum of the bone to the inside. Now, osteosarcoma can be mixed lytic, sclerotic, for example, in this case, in the proximal tibia of a child, and this is characteristic. When we done MRI for this patient, it showed that it was of nearly ISO to low signal intensity in the proximal tibia, and on T2 weighted image, it showed that it was a heterogeneous lesion. Clearly with a soft tissue component, as we can see here. So this is a case of osteosarcoma. We said one of the most important subtypes is the Parosteal Osteosarcoma. This is originated from the periosteum, grow outside. It often wrap around the diaphysis without breaking through the cortex. It is not aggressive, and even the treatment usually just removal, it's simple cartilage, or as deadly as long as it does not extend into the medullary portion. A common location is the posterior femur near the knee. Sometimes it can mimic cortical desmoid or myositis.
Parosteal osteosarcoma arises from the periosteum.
Yes.
Usually does not invade the bone. So they do surgery, they just remove the periosteum and the tumor and that's it.
Yes.
If it invades the bone, you treat it like an osteosarcoma.
Amputation usually.
Conventional osteosarcoma is very aggressive and everything else. Okay?
Yes.
So the cortex involvement is the key point here.
Yes. This is a lesion, destructive lesion. It is more dense to the in and faint calcification to the outside. On doing an MRI, it shows there is medullary involvement to the center of the bone. This is another case, as we said, in the posterior part of the femur, and also on doing an MRI on proton density, it showed there is abnormal signal intensity inside the bone or the medullary portion. Ewing sarcoma, this is one of the permeative lesions seen mainly in the diaphysis of the long bones, and they said 40% of the diaphysis, and the other percent can occur anywhere else, like metaphysis or in the float bones. Often we know it to have onion peel appearance, however, it can present, as this case, sunburst or amorphous calcification. This is case of Ewing sarcoma. Next one is chondrosarcoma. We said it's usually more than 40. Sometimes it's very difficult to diagnose, rarely occur in the children. However, it can be encountered in any patient already have osteochondroma. They said that we should not mention the word possible chondroma unless we have two things, painful or aggressive characteristics.
Possible chondrosarcoma.
Chondrosarcoma, yes, sorry.
Okay. If it's painful, if it has some aggressive characteristics, you mention just possible chondrosarcoma.
Yes.
Otherwise, it's in chondroma.
Yes. Also, this is chondrosarcoma. Considering the diagnosis, anytime, as we said, there is a bone soft tissue mass and with amorphous snowflake calcification in patient older than 40, and this is seen at the in the CT of the pelvis. Now, I think we talked about the giant cell tumor. We said 50%, and if there is a reoccurrence, we should think of malignant. Malignant fibrocystoma, this is, or the other name they called it fibrosarcoma. This is also lytic lesion, take any form. They said the age range usually at the fourth decade, and it is one of the few malignant lesions we talked about in the bony sequestrum that have. So this is a permeative lesion seen at the diaphysis. This is MFH. This is another lesion, lytic destructive, seen at the iliac wing as noted. And they said that it's a very slow growing tumor, and occasionally sometimes they have narrow zone of transition, such as in this case. Very narrow zone. Desmoid tumor, they said have a great fibrosarcoma. They have also benign periostitis with the thick spikes. It gives a multilocular appearance with a thick septa. They are very slow growing as well, and they do not metastasize. But however, sometimes, just as in this case, we see there is a Codman triangle suggestive that this lesion is more aggressive.
So you can see there are both benign features and malignant.
Malignant features, yes.
Because it's low grade sarcoma. Okay.
Lymphoma, it is also has a radiological appearance just similar to the Ewing sarcoma. It is a permeative or mouth-eating appearance. However, it tends to occur at older age group than Ewing. In comparison, number 2, it is usually asymptomatic, while Ewing sarcoma usually patients present with fever and pain. Metastasis, I think we talked about it. We all know that the sclerotic mainly from the prostate and lung and bowel and the breast sometimes mixed. We talked about renal. Multiple myeloma, I think we also talked about it. This is an MRI of the spine. See how it is mainly involving the vertebral bodies to differentiate it from the metastasis, usually involving the sparing the posterior element, while in the metastasis usually in the posterior element. So
medicals more involved
more,
in metastasis.
Yes. Now jumping to the soft tissue tumor, synovial sarcoma, or formerly called synoviomas. This is also a rare, originating from the joint, and typically it is homogeneous on T2. Sometimes we cannot differentiate it from a fluid. And here comes the importance of the contrast. When we give a contrast, it will take enhancement, and then we should suspect that this is a soft tumor.
Just keep in mind, synovial sarcoma, it's not in the joint. It's near the joint. So when you see something near the joint, you don't say, it's not synovial sarcoma because it's not in the joint. Okay,
yes.
Typically it's not in the joint.
Yes.
Okay?
It's adjacent to the joint.
Misunderstanding, you think it is because it's synovial معناها من الجوينت. لا.
Yes. Okay, the next one is synovial osteochondromatosis. This is a benign joint lesion from metaplasia of the synovium and lead to multiple calcified loose bodies. These bodies, and this is pathognomonic for this lesion. Up to, however, 20%, these loose bodies does not calcify, and when that happens, it will be mimic the pigmented volinodular synovitis, which is seen in this case. This can be one of the differentials. So, pigmented volinodular synovitis, it is also a benign process, causing joint swelling and pain with joint erosion. And on MRI, there is appearing of this synovitis, pigmented. Characteristically, it will be low signal lining the synovial. It's seen in T1 and T2 weighted image. So as you can see, there is abnormal low signal intensity in the synovium on T1 weighted image. On T2, also it shows that it also low signal because of the hemosiderin deposition. And they said one of the differential diagnoses is when there is a chronic hematoma. Also, there will be
I think even hemophilia will give the same appearance.
Yeah.
Hemosiderin deposition. But it will be a known case of hemophilia. So.
Yes. Hemangioma, often, as we said, it have a phlebolith associated with them, and this lesion sometimes grow adjacent to the bone, and that it causing compression leading to some cortical holes to the adjacent bone. Can mimic a permeative or mouth-eating appearance, but when we see the phlebolith, we should think of hemangioma.
إذا تجيك هيك صورة حتى لو بها phlebolith ماشي hemangioma تنزل البيت؟ لا والله ما أعرف هذا الشيء. صدق غير؟ it's aggressive pattern ما في.
At least we will see.
interrupted والدنيا والله شوية phlebolith خلاص hemangioma راح البيت.
Doctor, we said earlier that MRI is important.
You have to do MRI and CT and everything.
Yes.
Okay.
A typical synovial cyst, this is, for example, the Becker cyst around the knee, present as a soft tissue mass. On CT, the lesion may not be appreciated as a fluid filled, and their association with the joint can sometimes be overlooked. Therefore, the MRI will help us here. Will show a very high signal intensity on T2 weighted image, will be very homogeneous, and often will be septated. Also, will give gadolinium, because to see if it's a true fluid or solid tissue mass. So this is also a case of a typical synovial cyst. As you can see here, this is of low. Yeah. On doing MRI on T1 and T2 weighted image, it shows clearly that it is was a bright on T2 weighted image. So to proving that's a cyst. Thank you.
Thank you very much. First of all, thank you for your exceptional effort in preparing all of this in very short notice. Second, just a few notes. First of all, one of the things that was clearly said in the chapter is that the use of contrast is not very important in defining the tumor. You use contrast in MRI just to see whether it is a cyst or it is a soft tissue tumor that is so bright on T2. Otherwise, there's no need for contrast. Okay? احنا مو فرحانين كل ما نشوف every time we see a lesion in the MRI, give it contrast. No, it will give you no benefit. We have cost benefit, it will give you no benefit if it is not. If we are sure that this is a soft tissue tumor, you don't need to give contrast. First. Second, overall, by radiology, we don't have a diagnosis. The best we can do is provide this differential diagnosis. The importance of radiology is the extent of the tumor, where it is arising from, where it's extending to, what is invading, what is the tumor. في أحسن الأحوال بالضبط في أحسن الأحوال we give a differential of 4 or 5 possibilities. احنا مو pathologists, هاي pathology شغله نعطي diagnosis. Okay, so what we do is to provide description of the lesion and its extension and its involvement and its evolution over time. مثلا old كان smaller, it's bigger كذا. Okay, that's why it's very important for us to know the anatomy. يعني لازم أقول هذا diaphysial extending to which muscle, involving the neurovascular bundle, blah blah blah, the whole thing. Okay. حتى when we see a lesion that is hyperintense on T2 and we give contrast, كلنا نحتاج just one sequence to see the lesion enhancing or not. ما يحتاج coronal axial cycling تسوي لي fat cycle. It doesn't require all of that. Just give contrast, enhancing, okay, that's it. انتهى دور الكونتراست. يعني لا كلش فرحان يطلع contrast. Okay. So, any questions? Okay.
That being all your disease has no risk of malignancy.
Yeah, but ما فيهوش شيء يعني
What they have, but
Only
higher.
1% اتصور بالبرمجي.
يعني التجليد راح يشوف الاولير ديزيز 1% من عندهم راح يطلع ويصير كونترا ساركوما اللي هو لو جريد.
يعني أكو.
Yeah.